So just are you currently employed in either the emergency department or general paediatric ward as a medical or nursing employee?
Yes, emergency department. I'm employed as a nurse practitioner.
Cool. And you're a nurse. And have you worked, are you employed by nominated health service at Ballarat?
Ballarat. I'm also a locum nurse practitioner working in a few rural urgent care centres as well.
Okay. And have you been responsible for the management and care of infants with bronchiolitis and had access to high flow in your department up until this year?
Yes.
Excellent. So you're eligible, which is great. So thank you for taking part in this study. As explained, and I'm not sure if it actually got sent to you from Steve, because in the past he hasn't sent anything. But so I'm just going on the past experience. This study aims to identify and explore factors which influence the use of high flow for infants with bronchiolitis. Basically, it's a qualitative study that's being overseen by the Predict Research and Emergency Departments International Collaborative, and also forms part of my PhD studies as well. So excellent. Are you happy that you're to participate in the study and proceed?
Yes, I am.
Excellent.
Absolutely.
So the interview contains a series of questions about how infants with bronchiolitis are managed in your hospital and what factors may influence their management. We're speaking to both medical and nursing staff from a range of hospitals in order to learn from their knowledge and experience in regard to what care these infants are getting. Should take approximately half an hour. And if you don't wish to answer a question, please just let us know. And if you have to exit for carpet arriving or something, give us a yell.
Oh, good.
So yes, female. So how many years have you been working at Ballarat ED?
Full-time since 2009, and then off and on before, about 4 years before that.
Cool. And in paediatrics, that's a mixed department, isn't it?
Mixed department, we see 30% peds.
Yep. And you previously used high flow.
Yes.
So can you explain to me how infants with bronchiolitis are managed in the ED at Ballarat?
Or it can be a little bit variable on people's experience and knowledge. So I think a little while ago, the worst the presentation, so hypoxemia, worker breathing, people would put high flow on straight away. My practice is a little bit more ingrained with the current Rural Children's Guidelines. So I tend to go oxygen low flow, nasal prongs first off, and then if I have persistent hypoxemia or, increased worker breathing, not tolerating, then I'll go high flow after that. Sort of very depends on bronchiolitis. Dependent on doctors as well. Some people will trial salbutamol, especially if the child is closer to 1 or after 1 year of age. I don't tend to do that unless there has been a formal family history or previous viral-induced wheeze that hasn't quite been documented as bronchiolitis. But I generally don't treat with Atrin or Ventolin or anything like that with bronchiolitis. It's just really supportive management. Yeah.
What do you think are the key indicators for deciding on how an infant should be managed with bronchiolitis?
Their work of breathing, if they're hypoxemic, I wouldn't hesitate to put oxygen on. So I think we usually go around 90%. So if the SpO2 is less than 90% persistently, then I will commence some oxygen. If it's dipping very, very transiently short, then I won't. I'll see how the child goes. But if they've got a significant work of breathing, I will put it on regardless. But yes, usually I will put oxygen on lower than 90%.
What happens with an infant if they have okay saturations but worker breathing present? How are they?
Worker breathing's okay as long. It just depends on lethargy and fatigue and things like that as well. If the child is lethargic with their worker breathing and not managing well, then I think that's probably a reasonable indicator to put some high flow on as well.
Yeah. Do you feel giving high flow improves their outcome?
Good question. It makes them more distressed in the initial phase as well. So I the child has to be reasonably sick for me to start high flow. I generally try to go as hands off as I can. We have wafted oxygen previously as well. If the child's becoming too distressed, high worker breathing, and we've got concerns if we distress further, we're going to make it worse. So we might waft some O2 in front. What else? I can't remember what the rest of the question was now, sorry.
I think you've answered it. But that's okay.
Good.
What do you think are the benefits and the disadvantages of using high flow versus standard oxygen therapy?
Advantages, especially with adult population, you seem to decrease the actual work of breathing. You can titrate the amount of oxygen that someone's getting, so you can titrate it down if a patient is needing more flow to help with work of breathing as opposed to more oxygen for their hypoxemia. But kids are just completely different purely because of the fact that, they become some become very, very distressed when putting it on. So that would be the negative, I think. And I have had children that have become, distressed to the point that, their work of breathing's going through the roof. So we've aborted and wafted oxygen if we couldn't get anything near them.
Yeah. And benefits?
Benefits, improved work of breathing, able to titrate the oxygen to a low level as well. Yep. And more specifically to the child's age, without giving too much oxygen, so we just go the absolute minimum of what we need. Benefits, I guess, one of the things I guess is once it goes on, sometimes it can be a little bit hard to get off because the reluctance is to put it on, take it off, put it on, so we can't really see what the child's doing. And a lot of people leave the high flow on for quite a long period of time without actually seeing what the intrinsic sort of respiratory rate, work of breathing, everything like that is going, and if the hypoxemia is improving. So I think we probably sometimes leave it on longer than we should once we get it on.
Yeah.
And is that kind of like, do you have a weaning protocol, Abby, that you'd follow, or?
We don't know. So I'm not sure if the paediatric ward does, but we don't have a weaning protocol. I understand the Royal Children's is usually checking after a couple of hours and checking oxygen saturations and things like that, but we don't have anything active in the emergency department.
Right. Okay.
If high flow or standard oxygen is prescribed, but what happens if you question who's prescribed what?
Oh,
does that make sense?
Yeah. Sometimes, it will depend on person. So some people can get into a good, robust discussion with paediatrics and formulate an adequate plan. Other people have their own ideas on how to treat certain conditions at certain stages. So there can be some conflict of, where are we in the management plan? Are we actually going with evidence-based practice, or are we just trying to see what, works because of your previous experience? It can be conflicted, the information we get, and nursing staff sometimes get stuck in the middle a little bit there because they're essentially told what to do. But our senior nursing staff are very good. They usually are able to titrate themselves, and the doctor doesn't have as much input, but will certainly be guided with a prescription initially.
Yeah. Do you think there's any special skills or experience needed for high flow versus standard oxygen therapy?
I think for both, but more so high flow, just because of the specialised population that it is. That, can't give too much oxygen. How much oxygen do we need to give? How much flow do we need to give? So, even just working with my colleagues a lot, don't know that, as soon as we're looking at oxygen saturations less than 95%, people start to panic a little bit with kids. It's too low, it's too low, it's too low. But when we look at guidelines, the guidelines state differently. So, I think, nurses are told what to do. They will certainly speak up if they're concerned about anything. Our senior nurses will be good with the child's presentation, how we think the condition's going. But just very person dependent. We don't tend to follow a guideline strictly every time, if that makes sense.
And just, Abby, I'm interested, picking up on what you're saying about sort of the doctor-nurse thing. I'm a nurse practitioner. Shop as well, so it's quite interesting. I mean, in sort of your department and your role, So are you the person that sort of sees the child